Thank you once again, Michael, and thanks, Jean, for an insightful remarks there. And I would like to emphasize again on my part. I think it's really important to continue to collaborate and engage. And Michael called me an old man, and I'm just going to be really kicking myself, and I need to kind of do some makeover going forward. But you know what? I really appreciate Gene's comments and involving young people, students, and people who are really essential to understand the capacity building aspects of virtual care within the province. So I would like to see like more of involvement for Gene and Gene's colleagues and other people like yourself, Gene. So thanks for that. And now let me formally introduce Dr. Michael Krausz. I know Michael for maybe close to 9 years now, and he hired me to kind of bring me to Vancouver. I don't regret anything other than the rain in Vancouver, which is unbelievable. But anyway, I'm used to that now. So, Prof. or Dr. Michael Krausz is originally from Hamburg, Germany, where he was trained at the University Medical Center, Hamburg-Eppendorf. Following his training, he worked in 3 different clinical and research positions in general psychiatry. In mid-1990s, he became a founder, director of the Center of Interdisciplinary Addiction Research at the University of Hamburg and retained directorship at the center until 2004. As a founding director, he was also responsible for the German heroin trial, the European cocaine project, and several other notable addiction-related trials. He was also editor-in-chief of 2 well-established scientific journals, Such Therapy and European Addiction Research, respectively. He has also published more than 300 scientific papers to date, and I've not come across anyone with other than Michael with the energy and ongoing publication. It just keeps churning papers and churning good quality peer-reviewed articles and papers all the time. Dr. Michael Krausz is also founding members of International Society of Addiction Medicine, ISAM, and is currently serving on the boards of the Section of Addiction and Section of Public Policy for the World Psychiatric Association. Michael relocated permanently to Vancouver area in 2007 and became a professor of psychiatry at the University of British Columbia, UBC, as well as the Leaf Chair in Addiction Research at the Institute of Mental Health at UBC. He leads the Addiction and Concurrent Disorder Research Group and is chair of this virtual conference. And thanks for putting such a fantastic program, Michael. And I can keep going on introducing Michael, but maybe we will need the whole day. So let me just stop there. And I will continue to facilitate the next session, the keynote speech from Prof. Dr. Michael Krausz, will be presenting on the topic of virtual substitution clinics. Look forward.
Apologies, everyone. We have some technical issues. I'm going to share it again.
Hello, good morning. It's a great pleasure to see all of you today in our virtual conference. And I'm starting the conference with a presentation on virtual substitution clinics. And actually, I think it's really a fascinating, interesting development, which I would like to share with you. And I would like to use it also as an opportunity to talk about substitution models in general and how we possibly can care better and more attractive in the future. So virtual substitution clinics are potentially a blueprint for better care. And that will be my focus, not the technical details. I would like to advocate for integration of care and for a more holistic model of substitution, and which is going beyond just distributing certain substitution drugs. Okay, introduction, I'm the UBC Leadership Chair for Addiction Research. I'm also active very much internationally, so with the World Psychiatric Association and well-known organizations like the World Health Organization and UNICEF as advisors and expert. And I'm really convinced that in a lot of countries, we can only improve care with additional online resources and virtual resources. And the virtual substitution clinic is a good model of integrating the different settings of care to the best of our clients. Yeah, what you see here is our three components, more or less, on the treatment and the support for people using drugs. One is the safe injection site in downtown east side of Vancouver. And another topic is the distribution of substitution medications. And this methadone graph is a little bit to demonstrate that what we're doing is kind of an old story. Methadone is available since the 60s, more or less, and substitution treatment is right now the best established treatment for people using drugs. But it is following very different philosophies and different models. So let me dive into that. So the overview of my presentation will be, I want to talk about the reasons to improve our system of care. I want to advocate for integration of web-based resources and other settings of care. I want to mention and describe the opportunity of risk prediction using advanced technologies. And I want to talk about prevention, early intervention, especially in times of a historic opiate overdose crisis, which will become much better in the months to come, and we need to collectively address in order to stop that development. Okay, let's start with the first topic. Why is it important to reconsider the current system of care? So first of all, our system of care is not really for everybody. It's only able to involve a small minority of patients. So the coverage of substitution treatment, for instance, in Canada and in the US is between 20–25%, in a lot of areas even less. We have a lack of qualified and motivated physicians in several countries, and a lot of countries, the situation is now that the physicians started the treatment with methadone especially, are getting old and kind of tired, and they retiring. So, and there is not a lot of next generation waiting in the wings. So we need to figure out how to excite people for this very important area of care, but also to train new colleagues to make a good job. The quality of care and integration of care is also very limited. So a lot of the people using drugs don't have access to primary care. They have a hard time to get access to pain treatment. And they also, or infectious disease, all things which are coming with high-risk substance use. and the care, access to care is kind of hard to organize. And it needs to be, so walk-in clinics are not really a solution. In order to treat chronic concurrent conditions, you need a continuum. You need recovery beyond substances. If you have a look at the picture on the right, this is on the Burrard Bridge of Vancouver, where there was a symbol for every victim of the overdose crisis, a pair of shoes knotted to the bridge. And the numbers in British Columbia alone were over 2,000 in 2021. So how to integrate the different settings and how to make also organization of care easier. So I want to start with describing my understanding of care improvement. First thing I want to say, you need, in order to keep a quality system or develop a quality system, you need innovation. And innovation, in our case, where the system is really failing in the case of overdose, but as also before, retention rates in substitution treatment in British Columbia, but in other countries as well, was very, very limited, was around 30% for the first year of treatment. So the majority of patients were kind of leaving before a real recovery could start. So we need, that's my message, we need to disrupt in order to make the system work. The only way to big effects, significant effects, which we need in the current situation, is disruption. And that means we need to build a different idea. So I want to sketch that idea a little bit. So I think there are three core components in the future of care. One is what we already have, that's the green bubble, face-to-face, and the professionals are communicating with patients in the same room, talking to them face-to-face. We are only able to involve a very small minority of our patients, even in rich countries like the US or Canada or Europe, in this kind of care. The second setting are online, totally, a web-based platform where the user is interacting with a system. The user is in full control, it's easy accessible, there are no waiting times, and the purpose is, for instance, to be able to self-assess your situations, to navigate the healthcare system, to do online treatments like online CBT for specific health conditions, and also determine the level of your individual risk to experience an overdose. The system we are building that way is coming to the market in a few months. That's called the Risk Assessment and Management Platform. The third, the red bubble, is a virtual clinic where the professional is communicating with the web user in whatever communication channel is needed, especially the video conferencing is to name it, but also chat or email or anything. But you could stay in touch with your professional, your social worker, your psychiatrist, your addiction physician, your nurse, in whatever way is you want, if the system is set up and working properly. Okay, so a short summary again. So if you see the three small bubbles and how to address them, then you would kind of have three ways to implement that. One is what we see here is what I just called a web-based platform of RAMP or another web platform. then to provide the online care and communication in a virtual substitution clinic. And these systems could be integrated easily. And the last component would be treatment where people live, home outreach, and ACT so for the most high need populations. So you could bring care from where it is right now in clinics, in acute care, and in hospitals to where people live, and you could arrange it in a specific way, which I like to describe to you now. So if you imagine this yellow square, this online platform as a connecting dot, and direct healthcare professionals like nurses, nurse practitioners, and specific physicians are communicating through that platform with users and connect them either to advice or to specific informations. And they also including and connecting to partners in the healthcare process, like labs, like pharmacies, or housing partners. And that way, you could actually organize the integration of care through a web-based framework. That's kind of the main idea. And the clients would get access and could communicate through the platform in whatever way wanted. So another way to present the same thing, you would have the online component on in the yellow bar, and you would have the physical component in the green bar, and you could organize all the different steps in care with the support of the platform. And you could build, again, this is how you could build for all kinds of areas an integrated treatment approach, and including all the different capacities and strengths of the different parts of the system, overcoming the siloism in our system. Okay, so if you, another way to present that, you see, I love different pictures, colorful pictures. So the patients would, for instance, be able to organize themselves and their contact to the teams, and the team would support engagement through the online platform. The pharmacy would help to organize dispensation if so wanted. The peer program could organize support for the patients, and other healthcare services could be provided too. So it's really to think that the idea is to make access to care as easy as possible, and to make it as comprehensive as possible, because people, as you know, using drugs, they have all kinds of physical healthcare risk. They have very often a history of traumatic experiences and mental health challenges, and they have chronic pain. So just coping with drug use is not the full picture, and is not sufficient. Okay, from a user perspective, so there are different needs at different points in time, and the online resources could help with motivation, easy access, prevention, and understanding the healthcare system. So this is what we need to build, and which is possible to build, to mobilize the components and the resources, and to make care more integrated and successful. Okay, I want to touch base on risk prediction, because if you think that last year more people died of an opiate overdose than of COVID and suicide together. So the question is, how can we identify situations which need better care which need immediate intervention and crisis intervention. And how can we predict risk? And a method which is used there in a lot of areas is artificial intelligence, which means the risk factors are kind of known, but they are changing too. So the question is how to identify individuals in a critical situation and provide them with good care. For these young adults and adolescents, it didn't work. So it's heartbreaking for any health professional, but it's heartbreaking for the families and everybody to lose over 2,000 people in 1 year, and nobody is really making big efforts to change that. Everything was focused on COVID, rightfully to a certain degree, but I think it's unacceptable to go with these high numbers, and we need to figure out how to prevent overdose too. So I want to describe that to a certain degree. So for that, we need to have more information. We need to use information and data in order to predict that. And we're developing a system to do that. And the things to predict are not only overdose, they are also a critical situation, suicidality, or others. And the purpose is to make better referrals, to intervene early, and organize and figure out a specific crisis response for those in the highest needs. And that needs to happen quick. And the more time we are able to win through using advanced technologies, the better. And also for that, we need to create online resources too. So methods to do that are something which is called natural language processing or predictive modeling. For that, we need to collect information, and we can integrate that into the functional system of care and become able to intervene much earlier and hopefully prevent some of these events. But even if we only be able to prevent 10%, it would be 200 lives. Or if we are only able to prevent 20%, that would be 400 lives. We're talking about a significant amount of numbers and of people and of families suffering from the loss of their loved ones. So that brings me to the integration of prevention and early intervention. Prevention can mean an awful lot. It can also mean the prevention, for instance, of an overdose, but it can also prevention of deterioration, of infection, of severe physical health harms. So prevention is a broad concept, and the point is to bring it together with the right interventional strategies. And that means you need to be able to identify the risk. And if you integrate that with something like substitution treatment in a virtual substitution clinic, you are able really to provide a comprehensive level of care, which is much beyond of what we have now. Housing is a very important component in that, because a lot, or I say in single room occupancy rooms in Vancouver or other housing models, there are a lot of people with high-risk substance use, and a lot of them need substitution. Why not combining the strengths of the housing teams and the substitution professionals and the mental health professionals and so on in one place, and really developing a program which could work for housing providers? And for instance, just one example I added here, addressing pain is a critical thing, because about 50–60% of injection drug users report about pain, and pain is very often a reason to start opiates in the first place. So what are the advantages for the patients? Easy access is obvious. You can access the clinic and care and the people you need easily. You can also combine access to specific disciplines, and you could integrate it with online tools. Like you could actually really find out before you even talk to a professional what your symptoms looking like, whether it's severe or whether you think it's immediate action is necessary or not. And you can access direct online treatments like online cognitive behavior therapy, or you could communicate to somebody. So the integration of resources is absolutely a good thing, and it could shorten any waiting time drastically. And it would give users more control. And you could establish choice of medication much better. You could especially provide online psychosocial intervention. So it would give them more tools. And the integration of mental health and psychosocial care with substitution treatment or OAT would be, I think, an enormous improvement of the current model of care. And we could also support situations like the pandemic right now, or the HIV pandemic before, and helping with infectious disease prevention and control with public health measures and other things. You would have a network, you would create a network and a tool which really would address far more than just substance use. So the principles would be no harm, collaboration, so people could oversee, self-book and arrange their own care. They could work on their treatment goals, and it would build on strengths, not only on deficits and disease and pathologies. And the patients would get control in terms of data sharing. That would end up probably in something we really need, which is a continuity of care, which is a continuum, a clinical trajectory, because things here we discussing and mentioning are not a short-term issue. Okay, I will skip that because it carried me away. I love all these nice pictures. The healthcare improvement would be significantly. We would build capacity. The physician could whatever direct and consult wherever he is or she is. I would guess it definitely leads to higher retention rates and a better quality of care, as I already described, especially integrating psychosocial and substitution treatment in one. So I mentioned the RAMP platform. I just want to show you one screenshot, and in this conference, you will definitely be able to learn much more about that. This is a platform which is addressing risk, especially around substance use for now, and it will train and help to manage those risks with different, very interesting and accommodating tools. So it will be available soon. If you have questions, you can contact the Congress organizer. So that brings me to the end. You see here a picture in the downtown East Side, which is kind of a symbol of the current overdose crisis. And we are all kind of shocked about the situation over the last 7 years. The overdose crisis started 2015, and it was getting worse nearly every year. And we were not able to change that. We need to think about every possible solution, and we need to try everything in our skill set, in our range, to change the situation and to stop the bleeding. I want to offer you 5 conclusions from my subjective perspective. Virtual substitution clinics are definitely facilitating better access, are definitely the way for continuous mental health support. They are a tool for risk prediction and management, which is just starting to work, but it will get much better in the coming years. It is a next step to integration of care, and it's more effective. You can do more with the limited amount of experts, peers, and people in the network of care. So it's worth trying, it's worth considering. Let's have a conversation about virtual substitution clinics, and probably in the future, it will be the same for pain clinics, it will be the same for infectious disease clinics, and for other areas which need a comprehensive approach, which is strengthening our patients, improving care. Thank you very much for your interest.
Thank you so much, Michael, for a comprehensive and inspiring and innovative solution. So I just want to kind of highlight a couple of things, and also I have a couple of questions, before I turn to the audience and then look at some questions from the group. I hear loud and clear that we are kind of having, over the past couple of years or even longer, there's a lot of telehealth solution, virtual health solution that is being implemented across our province in different areas, including substance use care. But what I'm hearing very clearly, that a model which needs to be integrating several aspects of treatment, not just looking at the biological aspect, but biological, psychosocial, and other non-medical supports need to be integrated into a platform, including risk assessment, prediction management, and evaluation. That what I'm hearing, right? Got it. So
yes,
how do you see this getting done within BC? What are your thoughts on the next steps here?
First of all, I think it's important in the field and among professionals to develop a substitution model and a treatment model which is kind of covering all factors, not slicing our patients into different parts and distributing the parts all over the place. This is not going to work. If somebody is suffering with chronic pain for years and has no access to really good advice and pain clinics and appropriate medication or other treatment like surgery, then you can't be surprised if they try to self-medicate and then they try whatever they get offered. And we had the discussion on prescription drug use 10 years ago. It was seen as the main issue for overdose problems. It's obviously not that easy. So, and access to mental health care for our patients is a problem. We know that 2/3 of the patients injecting drugs in a lot of studies, 2/3 reporting early childhood trauma. So they have a long history of things happening. And we know that also from the research in Europe and other parts of the world. So yes, if we are not addressing the core issues driving opiate use, and especially injecting psychotropic substances, then we will not be successful in changing these, addressing these behaviors and avoiding the deadly outcomes we see right now. So I really think we should start the conversation on the model of care. We need to start the conversation on what kind of qualifications do we need in the treatment of substance users? What should be our focus? How can we collaborate on that? It shouldn't be a competition. It should be really a synergy. It should be a comprehensive process, and the only outcome which matters is we need to stop the bleeding, we need to stop the dying, and we need to engage them with the system of care. And patients will only come if they see a benefit for themselves.
Oh, thank you so much. I've got some questions coming up now, so I'm just going to kind of go through the list of questions. And the first one here is, in your opinion, Michael, what are the elements of a traditional care system that should stay the same and not substituted with virtual care systems? Or do you think all mental health services can be or should be provided virtually?
Okay, first of all, this whole discussion is not about a competition between meeting someone in a nice environment, talking, whatever, doing all what's necessary. It's if there are options like that, that is great and should be provided. But the point is, right now, the discussion is that if you have ongoing or chronic mental health challenges and problems, or are really suffering, you have to wait for months to see a psychiatrist, sometimes over a year. So if you can wait that long, you end up in an emergency room with another frustrating experience. So I think we need far more capacity, which is just not available for our patients. So, the question is, so what is good in the current history? There are several components which should be continued. But if you remember the three bubbles, the green area is much smaller than the other two areas can be and will be. And it should be especially be available for those with the highest level of vulnerability and disability, and which need kind of the personal attention. So if you want to take good care of the most vulnerable, you need to redistribute the resources we have in a way. They can't wait half a year to see somebody, then they're dead. And we need to understand that in the current situation that we have waiting times, we have not existing big treatment gaps, which are just unacceptable and deadly for a lot of things. So I will go through the components in my breakout session, and I'm inviting everybody. I wanted to say also, because I was placing my video a little bit in the middle, so sorry for that. I'm happy to share all the slides with you and just let the organizers know so that we are able to send it to you.
Thank you for that. So other interesting question what's come up, and something from your experience, Michael, I feel like you'll be the best position to answer this. Now, would you mind explaining the difference of actual situation in USA, that's in North America, to the heroin crisis compared to the one in Europe, and particularly in Germany in the beginning of 90s?
Yes.
And how do you think that they tackled it? And what are the insights and what are the learnings? And you think you would be able to share here?
Okay, that would be time for a whole would be a topic for a whole conference, but I will try to summarize it in an elevator pitch. So the situation in Europe in the 90s, late 80s and 90s was especially characterized to also a shift in patterns of use. So there was at that time, if you remember, there was the upcoming HIV pandemic. There was also a mix of benzodiazepine use and heroin use, at that time a more potent benzodiazepine, and an increase in overdose, and open drug scenes in all major European cities, like best known is Zurich, then Frankfurt and Amsterdam and London and whatever. And that situation became that it was not as deadly, not close to the situation in North America now, but it was very, very devastating, especially the HIV spread, growing level of violence in open drug scenes, and so on. And that led to a comprehensive shift in the treatment system with introducing heroin-assisted treatment in specialized clinics, access to substitution treatment the same day, access to any kind of detox treatment if patients wish so the same day, and mental health care integrated into the system of substance use. The role model for that is certainly Switzerland, but also in Germany and in 8 other countries in Europe, it led to the regulation of heroin-assisted treatment over a few years. In North America, the background noise is radical change in drug markets. We see catastrophic spread of synthetic opioids under street drugs, with fentanyl as a preferred drug of choice for a lot of people, which has such a high potency that the opiate tolerance is not protecting anybody, more or less. So, and then what we seen in the last months is even new drugs coming up, threatening the development, which are the mentioned carfentanil, which is a derivative from fentanyl, but also other synthetic opioids, and I can't go into details there. But if you're interested in that, we can also send you a paper if you want. Just request a paper on changing drug markets, and we're happy to share that on a personal level with you to have a better understanding of what's going on in North America.
No, thanks for that.
And sorry, one remark is also it's very interesting. In the US, for instance, there was a declaration of emergency related to the overdose crisis, but no new funds, no reorganization of the system of care, kind of a similar helpless response to Canada.
Yeah, no, thanks for sharing that, Michael. So I think what I'm hearing again is a lot more integration and trying to look at the problems in multiple levels, and not just kind of targeting one area of care. We need to look at the mental health, the pain management, other psychosocial aspects, and I think you're emphasizing that with a quick on a brief demo of what you did with your RAM platform. And I do understand your RAM platform is capable of kind of supporting these interventions. And it is live right now, or what? Or are you going to be piloting the RAM platform anywhere right now so we can see the results?
We are in the final stages of development. That is, it's an ongoing project. We're working on also kind of, if we can and we get the support from the provincial government or Health Canada to implement that as an integrated approach. I think we would be able to do that very soon. With our limited resources right now, will take us probably a few more months. But if you visit the breakout sessions with Dr. Kasemi, you will see where we are and what the tools are. But this is a new way, and we did a lot of work, but so that's kind of a proof of principle, and we will make it really work and nicely usable and implemented in service in collaboration with our clinical partners in 2022. So I think that is an opportunity. I see one question, if I'm here on the list, what changes needs to happen and how pain medication is prescribed. Am I allowed to say 2 sentences to that?
Yeah, that was coming to the next one. Thank you.
I think the core thing with pain treatment is the same with addiction treatment. You need ongoing counseling with pain specialists, also with psychologists, good pain treatment is not just the right and appropriate medication. It's also about how do you manage your lifestyle, how to strengthen your physical health. So it's very interesting that, for instance, if you compare Canada and Germany, both countries I'm very familiar with, in terms of use of opiates, prescription drug use, they are on the same level. But in Germany, you don't really have any significant overdose, no overdose crisis. Actually, the overdose deaths were decreasing. If you look at the same situation in Canada and in North America, in the US, you have a significant and dramatic increase in overdose. So obviously there is a significant difference in how care is provided. And that is, I think, so it's not just about medication, like in psychiatry, it's about the whole comprehensive approach of care. And that's also true for pain, and that's also true for infectious disease.
Oh, thanks a lot for that. I think I may squeeze in just one last question here before we kind of wrap up the session. Are you aware of any evidence-based virtual-based group programs which could serve the people who are involved in community court orders or criminal justice system?
There are no existing programs I'm aware of, but we are in discussions to develop those. And we are really think that is a fantastic area where we could do a lot, because also the capacity and the number of specialists in that field is relatively small, and we need to make it more effective in order to make health outcomes or improve health outcomes.
Yeah, no, thanks, Michael. I think thanks for such an inspiring and stimulating keynote on this area and on the virtual substitution clinic and integrating several areas of intervention into one-stop shop. I'm really hoping that this will take off, and we will see this pilot or this project shaping up nicely. And I'm really looking forward for our partners across the healthcare and the ministry to take a note on this quite seriously and move things forward so that we look at further innovative solutions. Whatever we have done, we are just fighting towards the tide, which we are really not able to kind of put our head out of the water. And it has been a sinking journey over the last 7 years. So I'm looking forward for further solutions and further opportunity in moving things forward. And thanks for kind of putting this presentation together. And I'm just going to tell the audience that we're going to be transitioning into about 10 minutes break. And we will be back at 9:20. And please come back to the agenda on the WOWA and join your respective Block 1 workshop on the breakout sessions, which will be at 9:20 a.m. I'd be starting soon in about 9 minutes. And thanks, everybody. And thanks for giving me the opportunity to share this. Take care.
Thanks much. Bye.